Imagine this. A patient comes in, just completely exhausted, struggling for every breath, gasping. Acute heart failure comes to mind immediately, right?
Absolutely. A classic and urgent scenario.
So for the ENARM exam, but also obviously in real practice,
Right.
what's the absolute must-know info to quickly diagnose and manage this?
That's exactly what we're diving into today. This is a really crucial review, especially for your ENARM prep. It's all based directly on the official GPC guideline, the Diagnóstico y tratamiento de la insuficiencia cardiaca aguda, the 2024 update.
Okay.
Our aim here is to give you the most vital, the most commonly tested points on acute heart failure. Keep it clear, keep it practical.
Perfect. Let's try and cut through the complexity of acute heart failure, ICA. We'll hit the definition, how it's classified, the big risk factors, diagnosis steps, and treatment. So starting basic, what is acute heart failure?
Well, fundamentally, ICA is a complex clinical syndrome. It means the heart's ventricles are acutely impaired. This leads to, fluid buildup and a serious drop in the heart's pumping ability, a cardiac output.
Got it. So with that patient gasping for air, what are the key signs and symptoms beyond the obvious breathlessness that really shout acute heart failure? What might trip you up on an exam?
Right. So typical symptoms are things like severe dyspnea, that shortness of breath when lying flat, orthopnea, and just general fatigue. But for more specific signs, you're looking for elevated jugular venous pressure, maybe hearing a third heart sound, an S3, or finding hepatomegaly. Less specific, but still important, things like peripheral edema, swollen ankles and crackles in the lungs.
Okay.
And here's a clinical pearl, really important for exams and practice. Severe dyspnea, especially orthopnea, or that sudden waking up gasping paroxysmal nocturnal dyspnea. That's a huge red flag for significant fluid overload. Needs urgent attention.
Right. That makes sense. So once you suspect it, how do you classify it to get a clearer picture and guide treatment?
Good question. The European Society of Cardiology, the ESC, gives us 6 initial profiles. Things like chronic decompensated heart failure, acute pulmonary edema, hypertensive heart failure, cardiogenic shock, right heart failure, and ICA happening alongside an acute coronary syndrome.
Okay, that's helpful for the initial presentation.
Exactly. Then we classify by left ventricular ejection fraction, LVEF. That's how well the left ventricle pumps. We say reduced if it's 40% or less, mid-range between 41 and 49%, and preserved if it's 50% or more.
And causes, like ischemic issues.
Yeah, ischemic cardiomyopathy is a really common cause for reduced or mid-range LVEF. And of course, we also need to think about right ventricular dysfunction separately.
And the NYHA classes, they're key too, aren't they, for severity?
Absolutely essential. The New York Heart Association class is grade limitation based on activity. Class 1, no limitation. Class 4, symptoms even at rest. Class 2 is slight limitation with ordinary activity. Class 3 is marked limitation. Knowing both the LVEF and the NYHA class, it's fundamental. You need it for diagnosis, for prognosis. Definitely something they test on the ENARM.
Understood. So moving on to risk factors.
Yeah.
What mainly drives acute heart failure?
Globally, the biggest one is acute coronary syndrome. But interestingly, in places like North America and Western Europe, you often see uncontrolled hypertension and cardiac arrhythmias as the main culprits. Other key factors, things like patients not sticking to their diet or meds, smoking, infections, worsening kidney function, even pregnancy can be a factor.
Right.
A big pearl for the exam. Remember how common underlying coronary artery disease and valvular heart disease are as the root cause of acute heart failure?
Okay, crucial context. So back to our patient. We suspect ICA. How do we confirm it quickly? What are those initial diagnostic steps and those biomarkers?
Right. The standard initial workup includes an ECG, a chest x-ray, and some basic blood tests. But the natriuretic peptides, BNP, and NT-proBNP, they're really central here.
Okay, the peptides. How do we use them?
They're excellent for ruling out ICA. If BNP is less than 100 pgml or NT-proBNP is less than 300 pgml, you can be pretty confident it's not acute heart failure.
That's a key rule out.
And for ruling in, higher levels support the diagnosis. So BNP at or above 100 NGL or NT-proBNP at or above 300 NGL. Keep in mind there are age-specific cutoffs for NT-proBNP too.
Got it. What about imaging? Echo.
Echocardiography, if you can get it, is vital. Abnormal findings like changes in LVEF, a dilated right ventricle, poor right heart function shown by TAPSE less than 19 millimeters, or a dilated inferior vena cava over 22 millimeters suggesting fluid overload. These are all linked to worse outcomes.
So for the exam.
Remember, peptides are great for exclusion. Echo is key for understanding the heart's mechanics and severity.
Perfect. Diagnosis clear. Now, treatment. How do we help this patient breathe easier right now? Let's talk diuretics.
Okay. For hemodynamically stable patients, furosemide is the go-to. You can give it as a bolus, or continuous infusion studies show similar outcomes either way. The really important thing, start with low doses.
Low doses first. What if that's not enough? If they're still congested?
If symptoms persist, the guideline recommends adding acetazolamide. That's 500 milligram IV every 24 hours, added to the loop diuretic like furosemide.
Acetazolamide. Okay. What about other diuretics sometimes used, like spironolactone or HCTZ?
Yeah, the guideline strongly advises against adding spironolactone or hydrochlorothiazide to loop diuretics in the acute setting. The evidence just doesn't support a benefit there.
Good to know. So the pearl here.
Acetazolamide is your add-on for diuretic resistance acutely, but watch out for those other combos that don't help.
Okay, clear on diuretics. What if even that combination isn't working? What about more advanced stuff like ultrafiltration or things like vasodilators, inotropes, opioids?
Right. If drugs aren't enough, ultrafiltration, if available, is an option. It might help reduce rehospitalization, but it can increase adverse events and doesn't improve mortality.
Okay. And vasodilators, inotropes.
Big caution here. The guideline strongly warns against routine use. Studies haven't shown they help clinical outcomes, and some, like milrinone or dopamine, might even increase mortality or side effects.
So avoid routine use. What about opioids, like morphine? Used to be common.
Also a strong recommendation against using them. Morphine is linked to a higher risk of needing mechanical ventilation, ICU admission, and even death. So definitely avoid.
Wow. Okay. Important safety points. Non-invasive ventilation, NIMV.
Also not recommended routinely for all ICA patients. However, it is specifically recommended for patients who present with acute pulmonary edema.
So specific indication there.
Exactly. For the exam, really know the indications and contraindications for these rescue therapies like ultrafiltration and specific NIMV use, and the avoid therapies like vasodilators, inotropes, and opioids. They love testing those.
Makes sense. One last specific group.
Correct.
Pregnant women. Any key considerations?
Yes, pregnancy itself is a risk factor for developing heart failure. The most critical point from this guideline for the exam is about treatment. Furosemide is contraindicated during the first trimester.
Okay, a key contraindication to remember.
Definitely.
All right, so I think we've covered the core ground pretty well. Definition, classification, risks, diagnosis, treatment, the tricky advanced stuff, and pregnancy considerations for acute heart failure. All based on that 2024 GPC. Mastering this is, well, absolutely key for the ENARM.
It really is. Best of luck with all your preparation. You can definitely handle this. And hey, if you found this deep dive useful, please do subscribe, maybe give us a like, and share it with anyone else studying for the ENARM.
Yeah, it really helps us out.
Let's just keep bringing you these focused reviews.
And maybe a final thought to leave you with. The real challenge in medicine often isn't just knowing the guidelines, but figuring out the when and the how for each specific patient. Acute heart failure management is a perfect example of that ongoing challenge.